Should I start?
Yeah.
Yeah. Can I start now?
Yeah.
Dr. Swaraj, start.
Shilpi, wait.
Shilpi, you stop. I will tell you when to start. Dr. Shilpi, you wait. I will tell you when to start.
Yeah, sir. I'm waiting.
Should I start?
Yes, please.
Good evening, everybody from EIZOC Secretariat. We are here again together for being a part of the webinar Ophthalmological Resident Teaching Series 14. ORTS will be giving us a platform for the young generation to come up with academic activities, and as a whole, with this type of programs, the bond between the states of EIZOC will be tightened. Through EIZOC, Eastern India is gaining its position and repute in the National Ophthalmic Forum. Our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, has framed the webinar in a meticulous way, supported by the Chief Coordinator, Dr. BNR Subudhi Sir, and the Coordinator, Dr. Ashok Nanda and Dr. Anurag Misra. The program is mentored by none other than our past President, AIOS, Dr. Ajit Babu Maji. Speaker of the evening will be Dr. Pradeep Vyas, the Medical Director, Center for Sight, Indore, who is a gem of the glaucoma person himself. We had a galaxy of panelists who are the masters in the field of glaucoma, which includes Dr. Sharmishta Behera from Orissa, Dr. Ajit Dwivedi from Bihar, and Dr. Vinayak from Palampur, Himachal Pradesh. Discussions are chosen from the different academic institutions across the country. We plan to do this type of webinar regularly, which will help us to know not only for the postgraduates, but also for the general ophthalmologist. And I like to use the platform to request all our viewers to cast a vote in favor of our EIZOC candidate, Dr. BNR Sir and Dr. Sabyasachi Patnaik. Thank you, sir. Over to our President, Dr. B.N. Gupta, sir.
Thank you, Suraj. I welcome all the participants of this webinar. This is a wonderful initiative, and the credit goes to the dynamic coordinator, Chief Coordinator, Dr. BNR Subudhi, and our Chairman Scientific Committee, Dr. Sabyasachi Patnaik. And of course, the mentor, Dr. Ajit Babu Maji, needs a huge applause from all of us. So this is going very strong. And today's talk is very important because
recording in progress.
We know that Dr. Pradeep Vyas is today's speaker, and he has been a very renowned glaucoma specialist of the country and also on the international level. So with this, I welcome all the participants, all the coordinators, discussants, panelists, and all the PG students, residents. So now over to our Chief Coordinator, Dr. BNR Subudhi. Thank you very much.
Thank you, our President and Secretary, EIZOC, our mentor, Dr. Ajit Babu, and Chairman Scientific Committee, Dr. Sabyasachi Patnaik, and today's guests, Dr. Pradeep Vyas. I welcome you all to today's program. Let me share the screen first. My screen is visible?
Yes, yeah. It's visible.
Okay, I welcome you all to today's program, the EIZOC Ophthalmology Residence Teaching Series number 14. Today's speaker is none other than one of the finest glaucoma consultant in our country, Dr. Pradeep Vyas. Our topic would be endophthalmic glaucoma, clinical perspectives. This is our team. Our mentor, Dr. Ajit Babu Maji, is always with us since last 3 years. In almost all our programs, he guides us. I am the Chief Coordinator for this program. Our The man behind this program is Dr. Sabyasachi Patnaik, the chairman scientific committee. Initially, we started the program in the platform of Odisha State Ophthalmic Society. Now extended the platform to the EIZOC states. Our president and secretary of EIZOC were always with us in these programs. They were encouraged to this sort of program for the postgraduate residents. These are my helping hands, Dr. Ashok Nanda and Dr. Anurag Misra. Today's speaker, Dr. Pradeep Vyas, to tell a few words about him. So he is presently the medical director, Center for Psycho. Urbanly, with the founder.
Slideshow mode. Slide is not changing.
Not changing?
No.
But I am changing. Okay. Sorry. Now?
Yes, yes.
Today's speaker is presently the medical director, Center for Site, Indore. He was the founder, medical director, and trustee, Sri Ganapati Netralaya Devgarh, Raja Marath Road, Jalan, 2007. And after that, he has also started this, became the medical director for the Shotram Netralaya Indore from 2007 to 2012. Since then, presently the medical director, Center for Site, Indore. There is a lot of awards and achievements to name a few. Raj Bahadur, Dr. S.S. Pandit Award, gold medal by Bombay Ophthalmic Association for outstanding service in ophthalmology, and the Marathwada Bhushan Award, Wagle Oration by Vidarbha Ophthalmic Society, Satguru Award in recognition of service to Indian ophthalmology. There are the few awards I could enumerate out of all these awards he has received. And he was, rather I would say, Honorary General Secretary of Glaucoma Society of India from 2014 to 2016. The President, Indore Divisional Ophthalmic Society, 2016-2017. The Vice Chairman, Organizing Committee of All India Ophthalmic Society Conference at Indore, 2019. But also Chairman, Organizing Committee, Glaucoma Society of India Annual Meeting, 2004. And also, he was the Chairman, Organizing Committee, Maharashtra Ophthalmic Society Annual Meeting, 2005. So these are all his achievements in his career. And he was formerly in the editorial board of Ophthalmic Surgery, Asian Journal of Ophthalmology, Master Journal of Ophthalmology, and CIAZIC Glaucoma Guideline, first edition. Presently, in the editorial board of Indian Journal of Ophthalmology. He has more than 300 publications, presentations, published 15 publications, 4 book chapters, and invited speaker in 10 societies. He has a lot of contributions in national, international, non-peer review literature in the glaucoma. So the glaucoma, one of the finest glaucoma consultant in our country, and we look forward to hear from him. I welcome you, sir, today's program, the ORTS 14. Today's moderator is Dr. Shilpi Agarwal. She is from Patna. She is the phaco and glaucoma surgeon, Lakvin Tralev. And our panelists today, Dr. Sarmishta Behra, Associate Professor Bhimsar, Burla, Odisha, and Dr. Vinayak, he is the Director and Consultant Phaco and Glaucoma Surgeon, Palampur, and Dr. Ajit Dwivedi, Director, Sarda Hospital, Patna. So these are the panelists for this today's session, and these are the chief residents for this program, Dr. Ankita Sharma from Patna, Dr. Aishwarya Bhatta from Cuttack, Dr. Sarika Rath from Bhubaneswar, Dr. Jyoti Goyal from Bhubaneswar, Abhiniti Siddharth again from Bhubaneswar IBPI, Dr. Sonali Singh from Burla, Dr. Mosam Mahant from IGS Raurkela, Dr. Lassini from Silchar Medical College, Dr. Juhi Gupta, Arayo, Kolkata, and Dr. K. Anusa from our hospital, Ruby Eye Hospital, Barampur. So, the next half an hour to 45 minutes, our speakers, panelists will be interacting with these postgraduate students. With these few words, I thank you. I welcome once again all for this ORTS 14. Now it is over to Dr. Shilpi to moderate the session, inviting the speaker first. Thank you.
Thank you, sir. A very good evening to all and one for this wonderful postgraduate teaching program. With all, I would like to call Dr. Pradeep Vyas sir to initiate the session. Over to you, sir.
Thank you, Shilpi. I'm really humbled and honored to be here with you
Make it
to
full
discuss
screen,
on the angle.
Pradeep, make it
Yes.
full screen.
Is it visible?
Yes, sir.
Am I audible?
Yes.
Okay, so good evening, everyone. I'm really humbled and honored to have this invitation from Dr. Ajit Babu. Thank you very much. And really, I would like to thank Dr. PNR, Dr. Patnayak, Dr. Trivedi, Dr. Gupta for having given me this opportunity. I would be talking to you on the angle closer glaucoma. Basically, as I was told that this is for the postgraduate student, and I'm sure that they will be benefited from this talk. I don't know how many of them have joined. Is there any postgraduate student who would be answering the questions? I don't think. No worries.
It's
Okay.
already 7, 8
Go ahead.
people still
No, no,
joined.
7 people
there.
have joined already.
Yes,
8 people are there. You can ask questions to them, and their names are there.
Okay. I will be happy if they volunteer to answer. Otherwise, yes, we will continue. So let us start with the angle closer glaucoma. The glaucoma is a very common disease, and all of us knows that it is the most important cause for the blindness, which is an irreversible blindness in entire world, not only in our country. So the primary open angle glaucoma and angle closer glaucoma both behaves little differently, and angle closer glaucoma is more notorious as compared to the primary open angle glaucoma, and it is more responsible for causing the blindness in the people. So what is the angle closer glaucoma and what is the difference? All of us knows that, the aqueous formation is here from the ciliary body, and it goes over here and drain out to the trabecular meshwork. When this trabecular meshwork is clogged with the peripheral iris, is a condition called angle closer glaucoma. In the open angle glaucoma, the iris does not block the trabecular meshwork, and the aqueous continue to come over here, but it finds resistance over the trabecular meshwork, and that's why it cannot egress conveniently out of the eye. And that is the open angle glaucoma. So this is the main difference between the open angle glaucoma and angle closer glaucoma. So what are the types of angle closer glaucoma? As angle closer glaucoma is primary as well as the secondary. And almost 20 to 25% of the cases are of this secondary angle closer glaucoma, and remaining 75% cases are the primary angle closer glaucoma. The classification of the angle closer glaucoma has changed a bit, and now we classify as an angle closer suspect, angle closer, where the intraocular pressure is high, but there is no glaucomatous optic atrophy, or there is no changes on the visual field, but there is an intermittent rise of the intraocular pressure. Sometimes it does manifest as an acute angle closer. Then is the angle closer glaucoma. The difference is that in the angle closer glaucoma, the changes of glaucomatous optic neuropathy started appearing, and you find changes on the visual field. And then it goes into the chronic angle closer glaucoma, where there is an advanced glaucomatous defect and patient start losing. All of you must have seen the glaucoma continuum from Professor Weinreb about the primary open angle glaucoma. This is the same thing as the glaucoma continuum for the angle closer disease. So it starts from the normal eye, and there are morphological changes in these eyes. What are the morphological changes these eyes have? They have the shorter axial length and decreased anterior chamber angle depth, decreased anterior chamber depth, increased lens volume, increased iris thickness, increased lens wall, and iris volume. So many of these processes are in the continuum. Is like the lens thickness continue to increase as the patient's age grows, and then it leads to the intermittent angle closer, and then it leads to sometime acute angle closer disease, and then it's angle closer glaucoma, and then it converts into the chronic angle closure, and then eventually it leads to the blindness. If you want to ask me about the epidemiology of the glaucoma, and in particular the angle closure glaucoma, I would like to remind you that almost 1% of the population in our country is suffering from glaucoma. And in India, almost 25 to 50% patients are of the angle closure glaucoma. Angle closure glaucoma, out of these primary glaucomas, that includes the normal tension glaucoma, primary open glaucoma, is more notorious, progresses very fast, and almost 90% of the blindness is because of the angle closure disease. So it is more responsible for causing the blindness. And obviously, it's more difficult to treat as compared to the primary open angle glaucoma, where the mainstay of the treatment is medical therapy. While for treating the angle closure disease, the mainstay is little different. How to diagnose the condition? When you have a patient, first you might be doing the flashlight test, which is obviously outdated, but the Von Herix still has a little role to play, though it has a very poor sensitivity and specificity. But still, once you put the patient on the slit lamp and you see that the anterior chamber depth is very narrow, then obviously you suspect that the patient might have an angle closure disease. And then what do? The gold standard is the gonioscopy. When you do the gonioscopy, first what you have to find? You have to find the Scholbe's line. And how can you identify the Scholbe's line? It is where the corneal wedge meets. That is the point where the Scholbe's line lies. And after this, there is a non-pigmented trabecular meshwork, pigmented trabecular meshwork, and then is the scleral spur, and last is the ciliary body band, where which may not be visible in every patient, but in many patients who have a wide open angle, you would be able to see the ciliary body band as well. So the gonioscopy is the gold standard for diagnosing the angle closure disease. However, as I said, that the Von Herix is a good screening tool, where you put the patients on a slit lamp and throw the light from the limbus, and you compare the thickness of the limbus with the depth of the anterior chamber. And if the depth of the anterior chamber is less than half the thickness of the sclera, then obviously you suspect the patient having angle closure disease. And then you do the gonioscopy. And there are a good number of gonioscopes available in your armamentarium, with handle, without handle, with indentation, without indentation. But obviously, the preferred nowadays is the indentation gonioscope, because it does not require the coupling fluid, and you can screen the angle in a very short duration at 360 degree, and you are capable of doing the indentation. What is indentation? I would be explaining you in a minute. So this is the lens which I prefer in my practice. This is the Sussman lens and 4-mirror lens, and it is an indentation gonioscopy lens. You look at over here. What you can see over here, there are no angle structure are visible. But when the pressures were applied over the cornea through this lens, and then you can see that most of the angle structure are visible over here. So this is what is the indentation gonioscopy, which differentiate between the synachial closure and the appositional closure. And when you start seeing all this angle structure, then obviously it is an appositional closure. If you don't see all this angle structure, then it's a synachial closure. So the indentation gonioscopy give you the chance to differentiate between the synachial angle closure and the appositional angle closure. There are some other newer tools are available to screen the angle. They have their utilities at some point of time, but they may not be a very good sensitivity and specificity. like this is the ASOCT. The problem with the ASOCT, it does give you a good image where you can sit with the patients and their attendant and can explain that what is the angle and why you want to do the laser iridotomy or why you want to treat that particular patient by seeing that photograph. But it cannot screen the 360-degree immediately or in very fraction of second. But it takes a hell lot of a time. It is a labor intensive if you want to screen the 360-degree angle. You have to really move the cursor 360-degree along, and you have to see every single part of the angle to screen the entire angle. But still, if you can screen the 360-degree angle with this, though it takes time, but still there are lots of problems with that. Like the first sign of the angle closure disease is the pigmentary clumps. The pigmentary clumps, you won't be able to pick up on this. The new vessels, you won't be able to pick up on the ASOCT. So there are so many drawbacks related to ASOCT, but still it is very difficult to identify the scleral spur in most of the cases. And if you cannot identify the scleral spur conveniently, then all your parameters go haywire. So these are the problems with the ASOCT. But okay, it's a tool where you can explain to the patient and to their attendant. But yes, the new tool is coming. Is a non-contact automated gonioscopy. Not yet a single equipment is available in our country, but I'm sure that soon somebody would be having it. And to me, yes, theoretically and whatsoever literature I have read and whatsoever discussion I had with the company who started marketing it in the Western world, it seems to be very promising. Where you can screen entire 360-degree angle, and even you can locate the pigmentary clumps and a small foreign body and the new vessels and so on and so forth. So it might be a very useful and very good tool if it comes, and if it comes at the affordable price. Otherwise, it might not be a good thing to have in the clinic, because nobody would like to spend so much of money. So now you have done the gonioscopy and you know that what structure you have to identify. Now you have to classify. So there are various formulas are available. Various systems are there to classify these angles, and they are the Schaeffer, Shees, Speth. But all these are very, very difficult to remember. And nowadays, no one follows these. And what we do is a goniogram. And how to draw a goniogram? It is just you draw a 360-degree circle, and at every clock hour, you have to mention that what structure you are able to see at that particular clock hour. Wherever you see the synechia, you can draw it. Wherever you see the trabecular meshwork, you can write the TM. Wherever you see the scleral spur, you can write SS. Wherever you see the ciliary body bed, you can write CB. So that is how you can draw the diagram of the 360-degree angle structure seen really by you. So that is a very easy way, and it does not create any confusion. If your colleagues are seeing, then they don't know by what system you have classified. If you have marked that what anatomically you have seen, then it becomes very easy for anyone to understand. So there are some risk factors for the angle closure disease, as I was discussing in the previous slide as well. The first and the foremost important is the short axial length. And it clearly explained that why it is more common in Indian and Chinese and in this part of the world as compared to the Caucasian population, because we have the shorter axial length as compared to the Caucasian population, who have a normal axial length of around 24 millimeter plus minus 1 standard deviation. However, in the Indian population, the standard axial length is around 22 millimeter plus minus 1 millimeter of standard deviation. And because we have a shorter axial length, so that's why the entry chamber is short and entry chamber volume is short. And we have a thick lens as well as compared to the Caucasian population. And the thick lens is one of the important risk factors for causing the angle closer disease. So you can really measure the entry chamber vault or the thickness by these newer gadgets. And that's why you can identify those patients who are at the more risk of development of the angle closer disease. Similarly, you can measure the angle volume by these gadgets, and you can identify those patients. The iris is also one of the important factors by which you can identify the patients who are at the more risk of development of angle closer disease. Over here, most of the patients who develop angle closer disease, they have the less crypt and they have the very thick peripheral iris. So the patients having the very thick peripheral iris and hardly visible crypt, they are more prone for development of angle closer disease as compared to the patients who have a more crypts and thinner peripheral iris. And this iris has a tendency to increase the volume once you dilate the pupil. While if the volume of the iris decreases after the dilatation of the pupil, that means that the patient is less vulnerable to develop the angle closer disease. So all these things can be measured and assessed by the newer devices like the ASOCT and the Pentacam. But obviously, these are not, very highly acceptable things by the glaucomatologists in the entire world. And these are really the risk factor, but it's still they are under research and the people are assessing and publishing the paper, and we are keeping a close watch. But still, you see that, if the patient has a very thick lens wall, and if this lens is removed, then what happens? You can see that the entry chamber volume has increased significantly, the depth has increased significantly, and see that there is a wide open angle, so which has a lots of free access for the ingression of aqueous very freely from entry chamber to the exterior of the eye. So that explains us and that tells us that yes, there is some sense when we discuss all these things. So now let us talk about when we discuss about the classification. The first thing comes is the primary angle closer suspect. So when you suspect any patients having an angle closer disease or possibly may develop an angle closer disease is an primary angle closer suspect.
Someone was asking about lens vault. They did not understand completely. Dr. Sarika. Dr. Sarika, can you ask Dr. Prati, what do you want?
Thank you, sir. Actually, sir, I didn't understand what exactly is the lens fault. Like when we compare these two pictures, I get a vague idea, like when lens comes forward, maybe that, but I don't know what lens vault is. Can you please explain?
So the anterior lens surface is usually a kind of a parabolic.
Yes.
But when it is a lens vault, so you understand the keratoconus. It becomes the conical. Similarly, in the lens vault, the anterior, this most central part of the lens, it bulge into the anterior chamber. And that is called as a lens vault. So how to measure it? To identify the scleral sphere on both the sides, and you draw a perfect horizontal line, and from the center of this horizontal line, you draw a vertical line and then measure it. This measurement is more than 1 millimeter, then the lens vault is significant. And these two are non-comparable because this is a pseudophakic eye and this is a phakic eye. So this is a lens vault. And when the lens vault is more, then obviously the irido-lenticular contact is more. And there is more chance of irido-lenticular contact. And that's why the aqueous cannot flow from the ciliary body to the anterior chamber. And once the aqueous cannot flow from here to here, then obviously there is more pressure in the posterior part and it causes bulge of the peripheral iris and eventually it blocks the trabecular meshwork. So that is what is the mechanism of the angle closure disease, and that is how it explains that how the lens vault is more important, because it makes iris more vulnerable for the irido-lenticular contact. Okay. Is that clear, Sarika?
Yes, sir. Thank you, sir.
So that's why the people says that you remove the lens and that is what happens. You can see over here. This is the artificial lens, and you can see that how it creates a difference, and you can really measure the angle. There are so many measurements that you can measure that. So we were discussing about the primary angle closure suspect. Okay, so what is the definition of the primary angle closure suspect? The primary angle closure suspect, it is very subjective, but when you do the gonioscopy and you find that almost 270-degree angle is oppositionally closed, which you are able to open on indentation, is a primary angle closure suspect. So once you diagnose a case as a primary angle closure suspect, then immediately your treatment starts and your further investigation must start, because you know for sure that you do not want any suspect to land up in a pathological condition. As long as the patient is a suspect, it's not a pathological condition. But once the patients land up in a disease, it becomes a pathological condition, and the angle closure disease is a very notorious. So what would you do? The most important thing, it might be an age-old test, but it is very important. So if you are not very sure, and if your two colleagues have a difference of opinion regarding the oppositional closure and the open angle, then you can subject the patient for a darkroom prone test. It is a provocative test. And on the darkroom prone test, if the pressure rises by more than 8 millimeter of mercury, then it is significant and the patient definitely falls into the category of primary angle closure suspect. Simultaneously, if you have a setup to treat the patient, even 4 hours later, then you can do the pharmacological test, and that is the dilatation of the pupil. And sometime you may end up in a trouble. And that's why I said that you should have to have a setup to deal the acute emergencies. So patient's pressure may go up to 60. But if you dilate the pupil and the pressure goes up by around 8 millimeter of mercury, then yes, the pharmacological provocative test is positive, and these patients fall into the primary angle closure suspect. So when you have
Pradeep, Dr. Ankita Sharma has some doubt about the PACs.
Yes,
Dr. Ankita, can you ask? Dr. Ankita.
I think sir is right now clear about that oppositional doubt. Like more than 270-degree opposition.
Yeah. She was asking 180-degree. Let her ask so that we can debate on that.
So there is, Shilpi, there is a problem. Actually, initially there were many studies where they have considered 180-degree as a oppositional closure as a PACS. But then it becomes a huge number. And once it becomes a huge number, then you end up in a trouble. Because once you diagnose a patient having a PACS, then you have to do the prophylactic iridotomy. And then there will be a huge queue. So that's why, the 270-degree cutoff is a reasonable, and you never overdo the YAG laser peripheral iridotomy. So the question comes when to do the LPI. That is $1 billion question. That do we do the LPI for all PACS? So yes, if I see myself patient having a 270-degree or more than 270-degree cynic, appositional closure, if I subject the patient for dark room prone test, then yes, I would do the peripheral iridotomy. But let us go to the next slide and see that in the Vellore eye study, the sample size was very small. They had two arms. One was a treated and another was a non-treated. Of a patients having a primary angle closure suspect. And Dr. Ravi Thomas did the 5-year follow-up of these patients, and almost 30% of the patients, they end up in a primary angle closure on a 5-year follow-up. So that's why there is a case that yes, if you diagnose a patient as a PSCS, then you should do the YAG laser peripheral iridotomy. But there is another ZEP trial. And many of you might be aware that again the ZEP trial was a very large sample size. They were recruiting almost 1,000 patients every month and a huge sample size. And when they compared the two arms of a PSCS, the treated versus the non-treated, there was not a significant difference on the long-term follow-up. The PSCS converted into the PSC only 0.4%. While in the non-treated arm, it was 0.7%. So there was a very small difference. Then it's a double number, but otherwise it's a very small difference. But there was a big problem in the ZEP trial. The ZEP trial, they did the dark room prone provocative test for every patient before recruitment. And any patient who was positive for the provocative test, they did not recruit the patient for this trial. So this trial does not tell us very clearly that if we don't do the peripheral iridotomy in a PSCS based on the gonioscopic finding, then what would happen? But still, come to the more clinical point. So, in my opinion, again, I would re-emphasize that if there is more than 270-degree appositional closure, then I would do the PI for the patient. If there is a positive family history of a PSCS, I would definitely do the PI. If the fellow eye has landed up in an angle closure or an intermittent angle closure, then definitely I would do the PI bilateral. If I have to dilate the patients repeatedly and the patient has a very narrow angle, I would definitely do the PI. If I know for sure that the patient would not turn up or may not turn up, then I would, for follow-up, then definitely I would do the PI for those patients, because we know for sure that PI, YAG laser peripheral iridotomy, has hardly any risk. It is almost risk-free procedures. So how to do the PI? Mostly we do with the anti-YAG laser, but whenever the peripheral iris is very thick and we are not able to see any crypt, then we use the argon laser as well. Doing the PI is a very simple. You must do either the Abraham lens or the Weiss lens to hold the iris, find out the crypt, preferably in the superior half from 10 o'clock to 2 o'clock, and use around 5 to 6 millijoule of energy. And usually, if you find a good crypt like this, then the single shot is sufficient. So if you have to, the peripheral iris is very thick, then you may have to use the argon laser. Never make an ego issue that you have to do the peripheral iridotomy in a one sitting only. You will do that, then you will end up in a problem, because once you have put 3-4 shots and you are not able to penetrate the iris, then it becomes very difficult, because there is lots of phase in the chamber lots of pigment in the entry chamber, and you are not able to deliver the appropriate energy, and the iris is very thin. So either call the patient, give the pilocarpine, and call the patient after 2-3 days once the inflammation subsides, and then you have a very good area to penetrate the iris. Otherwise, use the argon laser and do the thinning of the peripheral iris, and then use a single shot and penetrate the iris. And once you have penetrated the iris, there is immediate flush of the aqueous flowing from the posterior chamber to the anterior chamber along with the pigment. When you see the pigment, that is the end point. So never ever go by the retro illumination. Once your iris will become very thin, then also you will see the retro illumination. But many a time we have seen the retro illumination, but when we did the ASOCT, we found that it was not a penetrated iris. So that is a very important thing. So you see the pre-PI and you can see the post-PI. Yes, obviously there is a deepening of the entry chamber. And once the entry chamber deepens, then there is a more ingression of the aqueous. And if you ask me about the role of the peripheral iridotomy, apart from the pre-PSCS, then I would say that every single patient of an angle closure disease, whether it's a PSCS or a PSC or a chronic angle closure or even the acute angle closure, you must do the peripheral iridotomy. What you do in the acute angle closure? Let the acute angle closure subside. You can see over here, here, glaucoma fleckens, iris atrophy, lots of pigment over the corneal endothelium. And once the acute angle closure subsided, we penetrated the iris, and you can see that the pupil has also constricted. Subsequently, you can clearly see the glaucoma fleckens. And believe me, this patient did not require even a single drug for a few years. And obviously, you can see that there was a significant cataract. So after a couple of years, he underwent the cataract surgery. And but he did not require any medication even after a single episode of acute angle closure. So there are some complications as well. You know, once you see hyphema, immediately you press the globe with a thumb. If your patient is on a blood thinner, then you may ask the patient to discontinue the blood thinner. Ecoaspirin usually go well. But still, you know, theoretically, yes, they says that you must ask the patient to discontinue any blood thinner for at least 3 to 5 days before penetrating the iris. But if there is a bleeding, then don't leave the patient like that. Push the thumb pressure over the globe, and you will see that in a few seconds the bleeding will stop. But keep on giving a gentle pressure, not too much of pressure after that, because too much of pressure will elevate the intraocular pressure to 60 millimeter of mercury. So give a gentle pressure, and once you are 100% sure that iris is no more bleeding, then you can release the pressure and see that whether still there is a trickling of blood. Otherwise, the next day patient will come to you full of IV. But remember, there is one risk factor. The patient is on a dialysis for a renal problem, then always you have to be very, very careful, because this patient is on heparin. And I have seen one lady going blind and sue one of my colleague in my own hospital for 1 crore rupees for losing the eye. Obviously, the doctor has won the case, but yes, that can happen. Now, our standard teaching is that do the iridotomy from 10 to 12 o'clock. But now there is more and more people have started doing temporal iridotomy. For the simple reason is that you know, if you do the superior iridotomy, it causes lots of dysphotopsia. The dysphotopsia is because of the tear film meniscus from the lower tear film meniscus. So there are now quite a few papers about the dysphotopsia, and I have seen that many of our glaucoma colleagues, they have shifted to the temporal peripheral iridotomy, and even I do many a time temporal peripheral iridotomy, particularly in those patients where I find a good crypts. So we have already discussed these are the difficult situations where you don't find any crypts, and don't make it an ego issue. and always constrict the pupil. Try to look very carefully. If you can find the grip, then it is very easy to penetrate. Otherwise, just give a 2, 3, 4 shots and see if you can penetrate. Otherwise, call the patient for the next visit. So these iris are difficult to penetrate, but yes, you can penetrate these iris. And many of these patients, they do pretty well after the penetration of the iris, and either they require just a single drug or they may not require any drug, and their pressure is controlled. So now come to the management of the acute angle closure. Suppose your patient has landed up in an acute angle closure, then how would you treat? So we have to control, we have to deal with two things. Number one, we have to control the intraocular pressure as early as possible. And number two, you have to deal with the inflammation as well. To control the intraocular pressure, you need a hyperosmotic agent. And the hyperosmotic agent is the mannitol, then glycerol, then urea. I have never used the urea, but mannitol all of us uses very often. And the dose, remember, is 8 ml per kg body weight. It's very easy to remember from that. 8 ml per kg body. If you want to give a glycerol to the patient, then it's a 1 ounce, that is 30 ml, mixed with the fruit juice. And you may give 3 to 4 times a day. The patients require systemic carbonic anhydrase inhibitor, and you have to control the inflammation either with the NSAID or with the mild steroid like notalol or fluoromethanol, and try to create a meiosis. If you successfully create a meiosis, if you constrict the pupil, then immediately the acute attack will break. And then you would be able to penetrate the iris and do iridotomy. Now, the next condition, which mimics with the angle closure glaucoma, is a play 2 iris. And there are a few papers from our country itself where they says that almost 30% of our patients of angle closure disease have a play 2 iris. Our experience might be different, but we have not published any paper, so we cannot claim that. But you have to believe that almost 30% of our patients have a play 2 iris. And how to diagnose the play 2 iris? Once you put the gonioscope and you see the double hump sign, 2 humps, one at the peripheral iris and one at the mid-peripheral iris. So once you see the double hump, that is a play 2 iris. Why play 2 iris is more important? Because in play 2 iris, your Von Hennigs method fails. When you put the patient on a slit lamp, you see very deep angle and you don't bother to put the gonioscope, and that's why the standard teaching is that whenever you have any patient having a high intraocular pressure, more than 22 millimeter of mercury, you must put the gonioscope to see that what is happening to the end. And many a time you would be surprised, either you will see the sign we have seen, that is the double hump pattern, or you would see the angle recession, or you would see some other findings in that patient, and you will find the cause of the high intraocular pressure. No surprise. So when you have a play 2 iris, then the play 2 iris, the treatment is little different as compared to the angle closure disease. The play 2 iris, we do the iridoplasty. You can see that 360 degree, we have put the argon laser mark over here. And what happened over here? Once you put the argon laser marks over the mid-peripheral iris, there is a thinning of this iris and the pupil stretches, or the iris stretches, and there is an opening of the angle. And immediately the aqueous start egressing from here to here out of the eye. And we have found that, the single row of the argon laser does not work well. So we have started putting the 2 rows. And I don't do much. I do approximately 1 iridoplasty a month. Not much. But yes, whenever you are sure that this patient has a play 2 iris, then it is better to do the iridoplasty rather than penetrating the iris with the YAG laser. So once you have penetrated the iris, then how to treat the angle closure disease in this patient? So first you have to document the disease. Okay, So do the functional test, the structural test, do the OCTs, do the perimetry of these patients and document the defect. It is how you would be able to monitor the patient in the future. And then you have to control the intraocular pressure in all these patients who have angle closure glaucoma. So chronic angle closure glaucoma, there are two ways of treating. Almost all the patients, or most of the patients, they would require a treatment following the peripheral iridotomy on long-term follow-up. We have done a small study, and on 5-year follow-up, almost 100% patients require some form of medical treatment. So either you have to control these patients by medical therapy or by surgical treatment. So medical therapy, as I said, that many a time it's very difficult for the patient to comply, particularly patients coming from the rural area. So as you know that these angle closure glaucoma patients, their progress is very fast, they are fast progressor. So you do the trabeculectomy or you do any other glaucoma procedure whatsoever you are comfortable with. But the trabeculectomy in these patients work very well. There is a high incidence of the cataractogenesis because of the narrow angle and probably because of the little bit of manipulation of reformation of anterior chamber during surgery. You might cause little bit of trauma. So that could be the reason that why these patients develop little faster cataract. Valve can be done, but the valve is a difficult option. Either they sit on the iris or they touch corneal endothelium. The trep phaco, if the patient has a cataract, I always prefer doing a trabeculectomy along with a phacoemulsification. The clear lens extraction, we will come to that point. It is a little difficult point to address about, but yes, we will discuss about a few trials going on, particularly the Eagle trial on the lens extraction versus the peripheral iridotomy. So once you have a patient of a PACS and converting into the primary angle closure glaucoma requiring medical therapy, then what would you choose? So any medication, these patients, they start behaving like a primary open angle glaucoma once you have penetrated the eye. All the suppressants are effective. The beta blocker is effective. Topical carbonic anhydrase is effective. Alpha agonist is effective. So only the best is the biotic. I don't know why we hesitate using the pilocarpine drop nowadays, but still I would say that these drugs act like a wonder in the angle closure disease. And now again, it's freely available, the 2% eye drops. So use 2% eye drops, and believe me or not, our patients do not complain so much of pro ache and all. And if they do not have a cataract, and if they just have an angle closure disease, and you have penetrated the iris and require any additional medication, probably the myotics will be the most effective. The PG analog is also very effective. The standard teaching is that the PG analog requires an open ciliary phase, then only they act effectively. But even with the appositional closure, if you give a PG analog, then also through the scleral penetration, they act very nicely, and you get almost 30 to 35% of the reduction in the IOP from the baseline. And this is what the study we have published long before. This was the first publication about the 360-degree synechial closure in the angle closure glaucoma, and we have published that even with the 360-degree synechial closure, the pimetomast was able to reduce the intraocular pressure by almost 35% from the baseline. And still, if you are not able to control the intraocular pressure with the medical means, then surgery is the option. And we have discussed that the trabeculectomy works well. I am a little hesitant putting the CTON as a primary procedure. CTON is the valve procedure, whether it's a Orolep valve or a Hammond valve or any other valve. But I'm a little skeptical and hesitant as a primary procedure in my patient. I do not perform PGS anymore now. So lens extraction, yes, it's a hot topic, and we are going to discuss in the next slide. So what is the EAGLE study? The EAGLE study, they had two arms of an angle closure glaucoma. One arm of a YAC-TI and the second arm was a clear lens extraction. None of the patients had a cataract. So they compared the two arms and they comfortably says that the clear lens extraction is beneficial in an angle closure glaucoma because they reduces more intraocular pressure as compared to peripheral iridotomy. But you go to the fine print and you will find that there was additional reduction of just 1 millimeter of mercury as compared to the peripheral iridotomy. So for just reduction of 1 millimeter of additional IOP reduction, you would like to do the clear lens extraction? My answer obviously is no. But if the patient has cataract, then I would not hesitate in removing the cataract after doing the peripheral iridotomy. If there is a lens factor, that means there is a significant lens wall and very narrow volume of entry chamber, then probably I would prefer to remove the lens. So these are the conditions where I would prefer to remove the lens, like these kind of conditions, where the removal of the lens sometimes is beneficial. And if they have a mild cataract, then also you remove. But remember one thing, that the surgery with the patients who have a very less volume of entry chamber is very difficult. It's not very easy. And many a time, once you penetrate the entry chamber, then immediately iris start coming out. So make sure that the intraocular pressure at the beginning of surgery is very low. And nowadays, I have started using the Phenocan Plus for each patient dilatation at the surgery, at the time of surgery. Because if you dilate before the surgery, your nursing staff will start putting the drops 2 hours, 3 hours prior to surgery, and they will put the drops multiple times. And by the time patient will come to the operation theater, the patient's pressure will go haywire. So it is better to use the Phenocan that is available in your armamentarium. And remember that, if you dilate the pupil immediately, there is no right. Whenever there is a mid-peripheral contact of the iris to the lens, then only the pressure start rising. And that definitely you avoid the Phenocan. There is immediate dilatation and you finish up the surgery in a few minutes. Use the heavy ocular viscoelastic devices, OVDs, then you can do the cataract extraction very comfortably. And obviously, if the lens is the factor, then what it does, it increases the anterior chamber depth, removal of the lens, it increases the anterior chamber volume, it increases the angle opening distance, and it decreases the crowding of the iris at the angle. So because of these reasons, it may be helpful or beneficial in your patient in reducing the intraocular pressure. But still, if there is a permanent damage to the trabecular meshwork because of the intermittent rise, because obviously there is a damage to the trabecular meshwork after every take of angle closure. If there is a permanent angle closure damage, if you do the corneal synucleolysis, then also it does not work because you cannot restore the function of the trabecular meshwork. So in that case, probably subsequently you may have to do the trabeculectomy surgery. So there is only one person who was, the main person behind the EAGLE trial as well. Is a Professor Clement Hem, and all of us knows him. And he has done so many studies: phacoemulsification versus trabeculectomy, clear lens extraction in ACG, and phaco versus phacotrabeculectomy in chronic angle glaucoma. And in all his publications, he strongly recommend that you should do or you must try clear lens extraction. In my practice, probably I might be doing maybe clear lens extraction one case in a year, not more than that. That too in a very, very difficult situation where I do not find any other option to restore the patient, the vision, or to reduce the pressure. So now let us come to Dr. Ajit Babu wanted me to cover a bit about the secondary angle closure glaucoma as well. So, just a few slides. I don't know. Still, I have time. Is that right? Dr. Ajit Babu, do I have time?
Sanjay, make it a brief so we will discuss it.
Okay.
Pradeep, you have time. Take 5-10 minutes, no problem.
Okay, so I will finish the secondary angle closure glaucomas in a few minutes. So any glaucoma where there is an identifiable cause is a secondary angle closure glaucoma, and causing the angle closure disease is a secondary angle closure glaucoma. And secondary angle closure glaucoma is also classified as a secondary angle closure suspect, where there is just iridotrabecular touch. When you do the indentation gonioscope, that is relieved. So that is a primary angle closure suspect. The secondary angle closure is that there are synecdoche formation, but still there is no glaucomatous optic neuropathy. And secondary angle closure glaucoma is that where there are synecdoches and there is a glaucomatous optic neuropathy. And many of the PG students might be aware that there are two mechanisms for that. One is called as an anterior pulling mechanism, and other is called as the posterior push mechanism. This is a posterior push mechanism, and very classical example of this is the malignant glaucoma, where there is a aqueous in the vitreous cavity and which pushes the lens iris diaphragm, and the lens iris diaphragm come into the contact with the cornea. So that is a posterior push mechanism, and it is a anterior pulling mechanism. The clear example is the uveitic glaucoma, where there is a more pressure in the posterior chamber which pushes the peripheral iris, and there is a synecdoche formation. So that is that. So in my practice, almost 20% of the angle closure glaucoma are the secondary angle closure glaucomas. And the most common angle closure glaucoma in my practice is the uveitic glaucoma, is the neovascular glaucoma, the iridocorneal endothelial syndrome, and the malignant glaucoma. So all of you are aware that how the neovascular glaucoma occurs. So there is a retinal ischemia. Dr. Ajit Babu knows better than me. There is a vascular secretion of vascular endothelial growth factor. There is a angiogenesis. There is a peripheral anterior synecdoche formation, and subsequently leading to the increase in the intraocular pressure. You can see that there are lots of NVIs over here at the margin and over the anterior surface of the iris. You can see that there are lots of new vessels at the angle. So this is what the neovascular glaucoma is. And in the advanced state, this is a blind eye, and you can see that there is a retraction of the iris because of the fibrosis at the angle vessels. And you can see that there is an ectropion UV, and the pupil is dilated, and there is a, because of inflammation, there is a synecdoche formation as well. So this is the end stage of the neovascular glaucoma if you have not treated well, if you have not taken the help of Dr. Ajit Babu initially. So the treatment is obviously the underlying disease, which should be treated by a retinal surgeon. And the high IOP, yes, you can treat initially with a medical treatment, but ultimately you have to resort to the surgical treatment. The second is the most common is the uveitic glaucoma. You can see that there is posterior synecdoche, and you can see on the gonioscopy there are anterior synecdoche at several places and pigmentary clumps places. So there is a recurrent uveitis in this patient, and which is causing glaucoma. This is a pretty interesting case referred to me by one of my students only as a malignant glaucoma. Somehow, when I put the patient on the slit lamp, I also thought that it's a malignant glaucoma. There is no empty chamber. There is a total touch of the iris and the lens to the cornea. But when I subjected this patient on an ASOCT, I could find that there was a very narrow space over here, and there was a huge gap between here. It's a lens over here. So there was a pupillary membrane which was mimicking like a lens. And it was giving the appearance as if the whole iris lens diaphragm has come forward. So what I did, I just did the membranotomy with the YAG laser, and you can see that the whole, obviously there are permanent synechies and there is a cataract as well, but you can see that, how the entry chamber has formed this patient. And obviously subsequently, once the inflammation has quieted down, then we have removed the lens and we have done the trabeculectomy and we have restored the vision to the 660 to this patient. And there is another condition, which we commonly encounter is a secondary hemiplegic glaucoma, is a iridocorneal syndrome. And we know that this is a case of essential iris atrophy. And you can see that, I have put the express wall, a pretty old photograph. I might have done this surgery about 8-10 years before, and along with a cataract extraction. And this patient has done pretty well. And this is another patient of a Kogan syndrome, where I put the Ahmed wall, and this patient also did pretty well. These patients do not do well with the trabeculectomy, but the simple reason is that when this membrane is growing, then this block the deeper ostium immediately. This is again another patient of a Schindler syndrome or iris nevus syndrome, and this is the malignant glaucoma, aqueous misdirection syndrome. I have done the trabeculectomy. Patient reported to me about 6 weeks following the trabeculectomy, 60 millimeter of mercury pressure with very shallow entry chamber. Obviously, this chamber, after putting the patient on nitropin, drops. So this is what the patient, the pressure has come down, but you can still see that there is very shallow entry chamber, and the bleb has almost failed. So if you have a patient of a chronic angle closure disease, you have not reduced the intraocular pressure adequately, you have not given atropine post-operatively, just because of your ego, then sometime you will end up in this kind of a situation. This is my own patient. I did the trabeculectomy. I was pretty confident because at day 1, day 7, the bleb was very good. The pressure was normal. But before surgery, the patient's pressure was very high. And at 6 weeks, this patient presented to me with a 60 millimeter of mercury pressure. And believe me that subsequently, I have to remove the cataract. I have to put the wall. But still, this patient has a counting finger 1.5 meter. And in a couple of years' time, he has lost his vision. But obviously, he is asymptomatic, does not grip so much. So the aqueous misdirection is very, very difficult to treat. And whenever you have a patient with aqueous misdirection, and the strong cycloplegic is very important, and you have to put the atropine. Don't put on cyclomate or homide or so on and so forth, because only the atropine will work. So in conclusion, the angle closure disease is a disease of morphology of the eye. And in my opinion, all the patients of an angle closure disease, whether it's an acute angle closure or a PSCS, need a peripheral YAG-PI. If you have diagnosed PSCS appropriately, the ACG patients often need additional treatment to control the IOP over a 5-year follow-up. And wherever the lens is a factor in the angle closure disease, probably you may consider removing the lens. And if the patient has even a 1+ or 2+ nuclear cataract, always take the advantage of that and remove the lens. Probably it might be beneficial. Secondary angle closure, in my practice, is commonly seen condition, and most commonly seen is the neovascular glaucoma and uveitic glaucoma, malignant glaucoma, and iridocorneal endothelial syndrome. And always they are very difficult. Thank you very much for your patience hearing. I will be very happy to answer if there are any questions.
Very nice presentation and very informative too, sir. You already cleared many of the doubts. For the postgraduate, I'd like to say with all this talk, it is very clear that a gonioscopy is must for the complete and a comprehensive eye examination. Sir, I just want to know, for the postgraduate, which gonioscope will be more comfortable for them for the initial period, like a 4-mirror or a 2-mirror? Like
Your question should be that which gonioscopy lens should be preferred by the teachers to teach the student. Once the student has learned the gonioscopy, then obviously they have to buy the indentation gonioscopy. When I was teacher, I used to use a single mirror gonioscope, Goldman gonioscopy lens, because it is the best lens to teach the student because of the high magnification. It gives a very high magnification. It's always very good. If you are teaching your student to see through the slit lamp, but nowadays we have a camera attached with the slit lamp, and whenever I go anywhere to demonstrate gonioscopy live, I take my indentation gonioscopy lens only, and I teach us with that.
So in day-to-day practice also you are doing with the indentation gonioscopy.
Yes, and everyone, I would recommend to all students that first they should learn the gonioscopy either on Goldman 1-mirror or 2-mirror lens, and then subsequently whenever they are acquainted with the gonioscopy, then they should buy the indentation gonioscopy lens.
And one more thing, sir, I just like to ask from you: are you doing routinely repeated gonioscopy with for each patient after YAC PI? And
yes, see the gonioscopy story never ends. If you have diagnosed any patient right from PSCS to any stage of angle closure disease, the gonioscopy never ends. Like perimetry never ends. You always do for all glaucoma patient every 6 months or every 4 months or every year, depending upon the stage of glaucoma. Similarly, we have to do the gonioscopy at every follow-up the patient is coming to you. It just takes a minute. So the two lenses are always there on my table along with the slit lamp on my left hand side. One is the 90 diopter lens, and another is the gonioscope. So Dr. Ajit Babu Maji might be knowing, my 75% practices of glaucoma. So now I hardly see cataract, though I do almost 150 to 200 cataract every month, but still my majority of the patients are of the glaucoma. So I always do gonioscopy for all my glaucoma patient, and even for primary open angle glaucoma. Many a time, whenever I am in doubt, I immediately put the gonioscope and see. Just take a few seconds to screen the entire angle.
And apart from like dilating the patient, that cataract patient which having primary angle closer glaucoma on table, what all other measure you are taking for those patients while doing cataract surgery? Like you are giving IV mannitol for
two things. If you are dilating the patient with the phenotype, now it's a very good thing in your armamentarium. So it is very rare you give one tablet of Diamox preoperatively. You dilate the patients right on the table with the phenotype. The patient will never rise. But still, once you use the keratome, you enter the entry chamber, and if you feel that the iris is coming out, you use the high viscosity OVDs. Okay, so usually, yes, I uses the viscote in my practice, and I'm pretty comfortable with that. And I always ask my anesthetist to keep ready with the bolus mannitol. Never ever give the routine mannitol. If in emergency you have to give an intravenous mannitol, then ask your anesthetist to give 20 cc of mannitol as bolus. So immediately the pressure will go down.
We prefer to give IV mannitol in the block room itself. Like sometimes we feel that the giving mannitol make the case relatively very easy on table. So I prefer to give mannitol in the block room itself, like just beforehand, like 1.5 hours before the surgery.
Not at all a bad idea. The only problem I will tell you that before giving the mannitol is that, if you take some time, extra time, because you'll end up in some surgical complication, then the patient always have a problem of full bladder. So that is the biggest problem, and that I have faced in my initial stage in many patients. So I am very scared of using the mannitol because, Dr. Ajit Babu knows and Dr. Gupta knows that I was working for 15 years in a rural area in the interior Maharashtra. So where I used to do 30-40 surgeries in a day, and many patients of the ankle closer disease, and where we have to give the pre-op mannitol, and they have to void urine on the table itself. So thank God that we had a 12 operation theater in that hospital. So obviously we moved to other operation theater, and that's a very big problem. I'm telling you honestly. So always you try once, you will be very happy and very comfortable. If you have a problem, you try once, ask your anesthetist to give 20 cc bolus IV mannitol, and you will be very comfortable. Okay. Immediately the iris lens diaphragm will fall. Otherwise, in worst situation, you call your VR surgeon to make the scleroscopy and do a little bit of core vitrectomy. Iris lens diaphragm will fall down.
Thanks.
Mannitol push, it is. Develi wants to say something.
Yes, sir. What to say about sir presentation? It was so much informative and even learning for us as well. There are a few questions I think that PG should know beforehand. But it was whenever we have a glaucoma, we need to diagnose it first. Sir has rightly pointed out, and if you have diagnosed it in a way sir has narrated, it's very simple nowadays. So many of the problems of our management becomes very clear. That, and to sir, there is one question said how you select your iridoplasty patient among single closure glaucoma in your OPD, and when you suspect, better to say, sir.
See, as I said during my talk also, I don't do too many iridoplasty. I select the iridoplasty whenever I am 100% certain that this patient has a plateau iris. Whatsoever as reported in the literature, I don't want to contest because we do not have any publication on that or own. But I don't encounter so often, so frequently plateau iris in my practice. So, but whenever I am 100% sure that this patient has a plateau iris, then I will never ever put that patient for the GAC PI, and straightway I will take that patient for the 360-degree iridoplasty.
Yes, sir. And at the same time, when PACG, as you said, the PI should be there for all cases of PACG, primary angle closure disease itself, be it a suspect, be it a PAC, or be it a PACG at demonstrated. And when you prefer, sir, TAB, as you told that most of the time you do FACO and TAB for the PACG patient. So is there any special preference for that one, sir? Or sometimes there is another recommendation, you do TAB, control the IOP, and then go for the cataract if there is no cataract at that moment.
Yeah, it's interesting, and it depends upon patient to patient. So whenever I have a patient of the PACG and I have done the peripheral iridotomy and I am not able to control the intraocular pressure to my target level and patient is progressing on the visual field, then I don't have any other option except to take up the patient for a surgery. So I know for sure that if I would do a combined surgery, then there will be more reduction in the intraocular pressure. for two reasons. One, I'm doing the trabeculectomy, another, I'm doing the cataract surgery. So two mechanisms will act together and there will be a significant reduction in the IOP. But for that, my precondition is that the patient has to have the cataract. If the patient does not have a cataract, then I have to think 10 times whether I have to just do an anti-glaucoma surgery or I have to do the clear lens extraction or a clear lens extraction along with the trabeculectomy. Clear lens extraction along with the trabeculectomy, I have never done in my entire career.
Actually, that should be the clear message that unless there is a cataract, there should not be a promptness or there should not be a promptness regarding cataract surgery in a PACT case. I think so.
Yeah, you're absolutely right. You're absolutely right. As I said earlier also that I do only one test might be in a year time. And now believe me, many of these patients, they have a secondary angle closure glaucoma and they have forward subluxated lens. When you start doing the capsular excision, you realize that, patient has a subluxated lens and you are pulling the zonules. So many a time these patients, they have a forward subluxated lens.
Especially in those syndromic patients like...
Yeah, absolutely. Yes, Marfan syndrome and all. Yes, you are right.
Prateep, for laser PI, I have seen some people, they prefer two holes and many people have single hole. What is your preference?
So basically, you have to have a 500 micron hole.
Okay.
If you are not 100% sure that it's a 500 micron hole and you have done one PI and now there are lots of dust around, and as I said that you don't want to compromise your ego and you want to penetrate the iris in the same sitting, and you look for the another site. So that's why you see the two different PIs. But if you have done a single PI of an adequate size, that is sufficient to prevent the acute angle fussion. Yes. And the fluctuation. Fluctuation is important that I did not mention. I did not put the slide, and Shilpi and Ajit also did not mention it. That it is one of the very important factors that you prevent the fluctuation by doing the laser iridotomy. That is another advantage of doing the peripheral iridotomy.
Whenever you are doing PI, what is your preferable site? Either it's extreme periphery or a mid periphery. As you mentioned, in advanced cases, that there should be a mid periphery. But in a normal PACS case?
Yeah, I will tell you one thing. If you are doing an extreme periphery, you find a good grip, then also never indulge yourself doing at the extreme periphery because many a time I have ended up in a trouble by injuring the ciliary process. And if you put a shot on the ciliary process, you are going to have it. The bleeding, it is very difficult to stop the bleeding. Yes, it does stop, but it becomes little difficult. So don't go extreme periphery. Between the extreme periphery and mid periphery, that is the best side. And if you can find a good grip, then nothing like it. Then it's a gift to you.
Do you use pilocarpine prior to
100%.
PI?
100%. Without pilocarpine, I will never do.
And what about Abraham lens in all the cases?
See, there are two advantages of using these lenses.
Mm-hmm.
Number one is the magnification. And number two, you can fix the probe. Because I always tell to my patient is that it's a kind of a job of a goldsmith. So you have to do with a high precision. You need a magnification. So with these lenses, yes, you get the magnification and you can fix up the probe. And if there is a bleeding, you can prevent the bleeding very comfortably.
And what medication you prescribed after PI usually, and for how many days?
Usually I give fluorometholone 3 times a day for 5 days.
5 days, okay.
Yeah. And some of my colleagues, they give pilocarpine as well because they feel that the PI looks pretty good and iris remains constricted and the patient does not rise the immediate post-op period. But usually I don't do because I personally feel that it aggravates the inflammation. So I don't do that.
There is one usually a drug, the notorious drug basically used for the migraine that also creates some sort of secondary angle closure disease like symptoms or presentations, you can say. So how to detect and is your management plan for the all of us?
Which drug you are talking about, Ajit?
Topiramate,
Topiramate.
The topiramate toxicity is not very rare. In my entire career, I might have seen 5-6 cases. And if you put the patient on atropine, there is no need to do the PI. There is no need to do the PI. You just have to put the patient on atropine. The single drug is adequate to control the intraocular pressure. So if the patient is very high, entry chamber is almost flat, as Shilpi was telling, you give the intravenous mannitol 8 ml per kg of body weight, give tablet Timox, and put the patient on atropine. The patient will be all right in 2 days' time. 2 days' time.
Most of the time there is a confusion that there is a temptation to do the PI because the angle.
Why to do the PI?
That's why. Just yes, sir. How to differentiate for PGs basically, sir?
See, if you want to ask this question, then put like that how to differentiate between the malignant glaucoma and the angular glaucoma. So the simple thing is that you do the PI in the case of aqueous misdirection, and if your anterior chamber does not form, it does not deepen, then it's a malignant glaucoma.
Definitely.
Okay, but once there is a clear history of a topiramate, and you know that the patient is a young subject, then obviously there is no question of aqueous misdirection.
Definitely. History taking is very important, especially to diagnose such cases.
Yeah.
Excuse me, sir.
Yeah.
Sir, can I ask something?
Yeah.
Sir, you said about the plateau iris diagnosis confirmation before going for iridoplasty, sir. So plateau iris confirmation, sir, you do it with ASOCT findings or any other investigation, sir?
UBM also can be done.
Oh, yeah. But see, now, ever since I am this institute, I do not have UBM in my armamentarium. I have only the ASOCT, and I have to be dependent on the ASOCT itself. But as Dada was telling, that UBM is the best tool to diagnose the plateau iris. So you have to depend on your clinical acumen and your conioscopic findings.
Sir, and another question, sir. Why do you prefer fluorometholone instead of lotepred or any other steroid, sir? Is there any
because the fluorometholone has a better penetration in the entry chamber as compared to the loteprednol. That is, there is no specific reason for that. So probably the fluorometholone company might be sponsoring my to AIOC. There is no specific reason. You can use NSOID. I have been thinking a lot on this to use the NSOID for a very long time, but I'm not able to use it. It depends which rights. So I'm writing IoT for 30 years, 35 years. So I'm writing IoT. Still, I'm writing IoT. Whenever I have to give beta blocker, I write IoT. So if I have to give PG analog, I don't know whether 20 company comes or whatever. For 15 years, ever since it has come, I'm writing only one brand. I don't want to disclose, but I'm writing only one. I don't know. The pen writes it. If the company doesn't come, no representative comes to me, but still I write. When we were in LVP, Dr. Ajit Babu was junior to me in LVP. So at that time, we were writing Bizol. It was very common in LV Prasad Eye Institute, Dr. Satish Gupta, Dr. GC, Dr. Mandal, everyone used to write myself. And believe me not, for next 15 years, I was writing myself. And FDC representative never came to me. But still I was writing myself. So, you know, so there is no specific reason. I'm very sorry to say.
But sir,
I don't have any specific.
Sir,
I've also used a lot myself. Yes.
Sir, but IoT and IoT Plus, they are the readily available, I can say, regarding the pilocarpine availability and other things. They are very committed on that segment, and it's usually available. So that's one reason, and every ubiquitous presence as well. So we also prefer on that segment.
So when you do not have pilocarpine available with you, people, you can use IoT Plus. And believe me, that when even IoT Plus was not available, that is all because of this Caucasian, because it's a drug to treat the presbyopia. So it was not available. Then we have started using intracameral pilocarpine. And it worked. We used to open, and yes, we used to put...
Dr. Aishwarya, you can ask the question. Dr. Aishwarya.
No, she's not there. Yeah, she's there.
Yeah.
She wants to prescribe AGM after PI for control of the IOP spikes routinely?
What is the question? Repeat again.
Now, after the ACPI, do you use anti-glaucoma medication for reducing or preventing the pressure spike?
No, see, usually if I am available, you know, if I am going from the hospital at 4 o'clock, and if I do the PI at 3 o'clock, then I cannot ask the patient to wait for 3 hours, 4 hours to take the spike. So at that time, I don't use any anti-glaucoma drug. I just give one Diamox to the patient and call the patient to my next follow-up. Because, you know, the spike usually come after 4 hours, and usually it goes away in 12 hours time. So one tablet Diamox is okay.
So what is your review time? Like after doing PI, we usually call the patient after 2 weeks. What is your review?
I call the patient within a week time.
Okay.
The inflammation subsided. The pressure goes down. So I check the patency. I do the gonioscopy. I do the dilatation. I recheck the intraocular pressure after dilatation, whether it's working. And if needed, I do the perimetry.
So just 5 days of fluoroquinolone is enough for you, sir?
Yeah. 3 times a day for 5 days is okay.
Like Arvind practice, we are using that steroid drops for 2 weeks. The first week we are giving the 4 times, and the second week just for the 2 times, and it's a 2-week period.
Okay.
No prednisolone drops.
No prednisolone drops. You know, because I don't use too much of energy in my cases. So I don't see much of the inflammation, you know. Still today also, if Dr. Ajit Babu will see the statistics, I might be doing around 10 to 12 PIs every day. So I don't know. I'm able to penetrate comfortably with 5 to 6 millijoule with 1 or 2 shots in majority of the patient. But whenever I'm not able to penetrate, I don't struggle. I send the patient back and I call him sometime 2 to 3 days later, and then I penetrate. And if the patient is from outstation, then I ask the patient to wait for 2-3 hours. And most of the times, you know, it clears up and you are able to penetrate. Difficult situation comes, I don't deny it. But that yes.
With this practice, how frequent you find the post-laser spike? Because post-laser spike of IOP.
Post-laser spike, you know, usually whenever I check the pressure after 3 hours, 4 hours, it's not necessary that I am always checking the pressure after 4 hours. Many times it's after 2 hours also. So majority of the patients, they don't have an intraocular pressure of more than 30 millimeter. Majority of the patient. If there are lots of pigment in the entry chamber, then also it is around 28, 30. So I have never seen any patients having developed a compact epithelial edema, complaining of headache following the PI, or giving me a call in the midnight saying that, I have a severe headache and vomiting. My cataract patient, they do give a call sometimes. But the PI patient, I don't think that I have ever received any call.
Okay, sir. Thank you, sir.
Dr. Lessini, are you there? Dr. Lessini? Dr. Sonali? Yeah, you're silent. No doubts. Sonali?
I think all their questions are already answered.
Yes.
Yeah. Of course.
So I think it's a time to say goodbye.
No, it was a wonderful discussion, Prateek. Really wonderful.
Thank you.
A wonderful talk.
I think
Thank you very much.
Sabhisati sums up and give the vote of thanks. I request Mr. Rahul to play the video for the host. Mr. Rahul? Are you there?
Oh, Rahul has also gone. Dada, that used to happen frequently during high focus. Our host used to disappear because he has to go to Gurgaon.
Yeah, why not? Dr. Sarika, you can ask a question. You're welcome.
Thank you, sir. Sir, actually, in case of a hyphema occurs that sir mentioned in the complication of PI, when we start doing PI and there is suddenly hyphema occurs. Sir, after putting pressure, should we stop the procedure and call the patient for next time, or should we continue with?
No. See, if you will put a spot at the same site, you will traumatize vessel, then again it will bleed. So why to agitate that vessel?
Change the site.
Huh?
No. It's better to be at
do a different site.
Yes.
Select a different site and do it.
Thank you,
I
sir.
think wait for some time to hyphema to settle.
What are your parameters for iodoplasty? No one has asked. Actually, postgraduates, I expected they will ask you. Iodoplasty parameters.
Because this is your argon laser, huh?
No, see, they should ask all these questions. I told them, come prepared, so that. Actually, I appreciate Sarika is asking.
500 micron
prepared
spot.
well. That much
500 micron spot size. And 100 to 200 milliwatt power.
Okay.
So whenever you see the iris is contracting, that is the end point for you. So if it contracts with the 200 milliwatt, it is good enough for me. And it's 0.1 second duration.
Yes.
And it's around 6 spots per quadrant in 2 rows. So 6 plus 6, 12. So it comes to around 48 spots.
Rahul, are you there? Yeah, Sarika, you want to say something?
No, sir, I just said thank you.
Thank you.
That's good. Okay, Mr. Rahul.
Rahul is not there, sir.
Rahul is not there.
Rahul, yes. So
let us find out.
Leave Rahul.
Yes. If not there, we will pass it on to Sabitaji.
I on behalf of EIZOC,
Yes.
so extend my profound thanks to Dr. Pradeep Vyas. I know him since long. He's a very cool, composed, and dedicated and a focused glaucoma consultant. So there are many things to learn from him by observing silently also. It is not that today he discussed so many things, all aspects of angle closure and secondary angle closure in such a beautiful manner. I think our postgraduates and residents, they must have been benefited quite immensely out of this discussion. I thank Dr. Silpi for moderating this so well, and Dr. Ajit also for helping her in making this discussion more lively. So, as always, I must thank Dr. Ajit Babu, our mentor, who is the main source behind our inspiration to conduct this program continuously for the last 3 years. First, we started from our state, Odisha State Society.
Then we are conducting at EIZOC, and we expect, or we hope, by the grace of God, we can continue doing it at national level also. So I thank our President, Dr. B.N. Gupta, who is a constant source of inspiration for all of us, and mostly the EIZOC family, I must say, because we behave and we also act like a family, the entire EIZOC family, 7 states and the Northeast. So I thank the participants, because we started this active interaction with the participants virtually for the first time. Then it was followed by other zones, yes, other zones and national level, because we started thinking that we must keep them as discussion, so that it will be like a active classroom type of participation. Mostly we started this during Corona time. So at that time, there was very less scope for physical interaction. So this was the concept, and which gained importance all over India. So I'm very much thankful to EIZOC also, because we are conducting continuously every month 4 programs. One is this resident teaching series, and another is ophthalmic research and publication series, where many of our residents have started writing articles, and also they are organizing their thesis, because in our time this scope was not available. We didn't know how to write a thesis, how to write a protocol, what is there, what should be there. At the end of the thesis, when the thesis writing comes, then we think how to write it. Then the statistician says nothing can be done. There is so much of this thing, that thing. So what is required for residents is they should know how to organize their research. They start with their thesis writing. And
most of the time we used to copy the old thesis.
So such was the time. But now things are changing. Now things are changing, because our residents are also participating in competitions.
I can definitely say thank. There was one program I have attended with this research related systemic meta-analysis, and I definitely came to know regarding it. It was such a systematic review, and it was well appreciated in our section, and that program should go at a national level.
So that's it. So I request everybody to encourage us and participate in our program, so that I will continue this program, being inspired to conduct it and continue, because we have to put a lot of, Ajit Babu is taking a lot of pressure and tension in organizing this program. So we need all active cooperation and support from all the postgraduates and residents. I thank all of you for your active participation. Thank you very much. I thank Entod, who is continuously providing us the platform for this program. So thank you all. Thank you, Dr. Pradeep.
Sarika, you want to ask some question? Or you written something there. Can I ask one last question?
Sir, I wrote that before.
So that's the
10 minutes back. So.
Oh,
finish that question.
Whatever is there, I'm reading it. Okay, fine.
Thank you very much. Thank you so much for joining us.
Thank you.
Really wonderful evening.
Thank you, sir.
Good night, both of you.
And all the best to
ORTS program, just like iFocus. So
all the best to Dr. Subudhi, Dr. Sabyasachi, Dr. Gunasagar Das.
Thank you, sir. Thank you, boss.
Thank you.
Who is the third one?
Don't worry.
Who is the third one?
Yes,
Gunasagar Das. He's the member scientific committee.
Okay. My best wishes to Dr.
We are not
and Dr.
discussing
BNR.
the elections here.
Yes.
You should be neutral.
Election week now going.
You should be neutral.